Welcome to the 2018 CADTH Symposium. Let me begin by acknowledging that we are in Mi'kma'ki, the ancestral and unceded territory of the Mi'kmaq people. This territory is covered by the treaties of peace and friendship, which Mi'kmaq and Wolastoqiyik people first signed with the British Crown in 1725. The treaties did not deal with surrender of lands and resources, but in fact recognized Mi'kmaq and Wolastoqiyik title and established the rules for what was to be an ongoing relationship between nations. Let me also take a moment to recognize all of the members of Canada's Armed Forces who are with us today and to thank you for your service to Canada. And a big hand for our military members. There will be much to discuss and celebrate over the next 2 days, but before I begin, I just want to pause and take a moment to reflect on the devastating accident in Humboldt, Saskatchewan. This tragedy has deeply affected Saskatchewan, Western Canadians, and in fact all of Canada. En tant que parent et ancien entraîneur de hockey, c'est difficile pour moi d'imaginer toute la peine que vivent ses familles, ses amis, et leurs proches. Our thoughts and condolences are with them during this difficult time. Now, first responders and healthcare providers are highly trained for these types of incidents, but no amount of simulation can fully prepare you for the unthinkable. The road ahead will no doubt be difficult, and we must all stand together to offer those impacted by this horrible tragedy with the care and support that they will need in the weeks and months ahead. So it's been 8 years since we last held the CADTH Symposium in Halifax in 2010. Je suis très content d'être de retour à Halifax. C'est l'une de mes villes préférées dans le monde entier. Now, I might be a bit biased because I was born here in Halifax. I studied at Dalhousie University just down the road. I met my beautiful wife here. One of my children was born here. And I worked here early in my career. Néanmoins, je suis toujours heureux de revenir. Et je suis tout particulièrement content d'être ici pour célébrer une étape importante pour mon alma mater. C'est le 200e anniversaire de l'Université Dalhousie. Last night at the welcome reception, we heard a little bit about DAL 200, the year-long celebration of the university's bicentennial from Dr. David Anderson, Dalhousie's Dean of Medicine. And today, I'd like to acknowledge those of you whose lives and careers have been shaped by DAL. As part of the symposium registration process this year, we asked people to tell us if they had a connection to Dalhousie, and about 10% of you said you had a distinct connection. Il y a des personnes ici qui sont étudiants. Il y a aussi des professeurs ou des anciens étudiants. D'autres ont des conjoints ou des enfants qui étudient à Dal. The alumni, dating back at least as far as my class, 1980, and I know some of you were here before me, but maybe you didn't put that year down. They come from across Canada, and they're embedded throughout the healthcare system, from health ministries and hospitals, to industry and consulting groups, to patient groups, and of course to CADTH and other HTA and evidence-driven organizations. Bon anniversaire à l'Université Dalhousie, and best wishes for your continued success. With the symposium back in Halifax after 8 years, I can't help but think about how much has changed since 2010. For one thing, Donald Trump is no longer the star of a television reality show, although one could no, I won't go there. And perhaps it's just my memory playing tricks on me, but my favorite donair shop in Halifax, aptly known as the King of Donair, which used to be just around the corner at Pizza Corner. It seems it's moved now to Quimpool Road. which is just a little bit too far to go after a night of revelry at the lower deck. And if you haven't been to the lower deck, if this is your first time in Halifax, you need to go experience it. It's a unique tradition in Halifax. And there's been profound changes in healthcare in Canada. 8 years ago, very few people were talking in depth about an opioid crisis. 8 years ago, the Truth and Reconciliation Commission of Canada was in its early days. They released an executive summary of their findings in June 2015 with 94 calls to action regarding reconciliation between Canadians and Indigenous peoples. Il y a 8 ans, plusieurs des médicaments, des interventions cliniques et des dispositifs médicaux novateurs qui sont maintenant entrés dans l'usage et étaient à différentes étapes de leur développement clinique. Things like continuous glucose monitoring, the direct-acting oral anticoagulants, virtual treatments, such as internet-delivered cognitive behavioral therapy, telehealth, and mobile monitoring, and the new drugs used to treat hepatitis C. Along with the influx of new drugs and technologies, we've also seen some major shifts at senior health policy levels. Now, here's a fascinating statistic. There isn't a prime minister, a premier, a health minister, or a deputy minister of health from 8 years ago who still holds that same position today. Et avec de nouveaux décideurs en matière de politique, il y a assurément de nouvelles orientations et de nouvelles initiatives. En 2016, les ministres de la Santé de tous les paliers gouvernementaux se sont entendus pour agir ensemble afin de faire avancer leurs priorités communes. Ce sont l'amélioration de la santé pour les Autochtones du Canada, l'amélioration des soins à domicile et communautaires, et l'amélioration des soins pour ceux qui souffrent de maladies mentales et de dépendance. Budget 2017 provided significant new funding for Health Canada, for the Patented Medicine Prices Review Board, PMPRB, and for CADTH to improve the accessibility, affordability, and appropriate use of prescription drugs. And more recently, the 2018 federal budget, tabled on February 27th, announced an advisory panel on the implementation of pharmacare to be led by Dr. Eric Hoskins, who stepped down as Ontario's health minister to take this on. And most recently, in late March, an external review of 8 federally funded pan-Canadian health organizations, including CADTH, was released by Federal Health Minister Jeanette Petitpas-Taylor. Le rapport donne une vue d'ensemble de toutes les organisations. Il propose aussi quelques idées au gouvernement fédéral sur la façon dont les organismes qu'il finance peuvent s'adapter pour mieux influencer et mieux soutenir un système de santé moderne pour le 21e siècle. While all of these announcements and reviews were taking place, the CADTH Board of Directors and staff were planning for the future. In 2016, at the request of the federal Deputy Minister of Health, Simon Kennedy, and with the support of the Federal, Provincial, and Territorial Conference of Deputy Ministers of Health, CADTH developed a proposal to transform how we manage health technologies in Canada in support of the triple aim of better health, better patient experience, and better value. That proposal detailed our thoughts on the concept of health technology management and provided the vision and direction that shaped CADTH's new strategic plan for 2018 to 2021, which I'm tremendously proud to officially launch today. You'll be able to pick up a copy of the summary document of our strategic plan as you make your way out of the plenary room. You can access the document on our website and just drop by the CADTH booth, and we have full copies of the strategic plan at our booth. Titled Transforming How We Manage Health Technologies, our strategic plan sets a path for CADTH's transformation from a health technology assessment organization to a health technology management enterprise. And despite having been developed through an entirely separate process, I'm pleased at how consistent our strategic plan is with the direction articulated for CADTH by the authors of the Pan-Canadian Health Organization Review. I'm proud that on many fronts, CADTH is already moving forward on concrete improvements to our pharmaceutical review portfolio that will help us adapt to meet the changing needs of governments, of clinicians, and of course, for patients. Our plan contains some specific objectives in this area, things we've been talking about at CADTH for a number of years, including better alignment with Health Canada and the regulatory process, stronger support to PMPRB and the Pan-Canadian Pharmaceutical Alliance, and things like reassessment and disinvestment and much more. We're also well underway to extending our reach and strengthening our partnerships with respect to medical device assessment and implementation support, two other key areas that were addressed in the external review of the Pan-Canadian Health Organizations. The Pan-Canadian Health Technology Assessment Collaborative comes to mind as just one example of how we are living the value of collaboration in the devices space by building on the strengths of our provincial HTA partners. Nous vivons à une époque pleine de défis et passionnante pour les soins de santé au Canada. Vous verrez que cela se reflète dans l'ambitieux programme que nous avons préparé pour l'édition 2018 du Symposium de la CMTS. Our theme this year is Managing Health Technologies, Supporting Appropriate, Affordable, and Accessible Care, which captures not only CADTH's new direction, but the task we must all face collaboratively moving forward. We have 3 really exciting plenary sessions, and in between those plenary sessions, you'll hear from clinical and scientific experts, decision makers, patients, industry representatives, and students from all across Canada and abroad on a wide range of topics relevant to the theme. Once again, we have great representation from across Canada with delegates from all 10 Canadian provinces, from the Yukon Territory, and the federal programs involved in healthcare. We also have excellent representation from our colleagues and partner HTA organizations in Canada, from INES au Quebec, Health Quality Ontario, the Institute of Health Economics in Alberta, and the BC Health Technology Review. We have international delegates from Switzerland, from the United Kingdom, from Taiwan, and the United States. We're proud to once again be officially recognized as a Patients Included event. We continue to add new elements to enhance the patient experience at our symposium and to help them feel engaged and welcome. This year, at their request, we created a quiet room on the summit level for patients or for anyone who needs a quiet spot to recharge before taking in another session. Students are also well represented at the symposium this year, including many whose scientific posters were featured at last night's welcome reception. Nous continuons aussi à améliorer l'accès au symposium en diffusant certaines séances en ligne, par webinar ou par diffusion en direct. En tout, nous offrons 5 séances aux gens qui ne peuvent venir ici en personne, dont 3 séances plénières. And rather than continually expanding our offerings, this year we're actually taking something off the table at the symposium, and that something is sweetened drinks. Our decision to remove sugary drinks from the menu in favor of healthier drink and snack options resulted in a commendation from Diabetes Canada. And finally, as Peter said, a reminder that this is a social media-friendly event. You're encouraged to tweet throughout and after the symposium and to share information through other social media platforms. And while you're in Halifax, I do hope that you'll have some time to enjoy some of the many wonderful things that Nova Scotia has to offer. For example, music and dance are an intricate part of Nova Scotia's Gaelic culture, from jigs and reels to fiddles and step dancing, bagpipes and good old-fashioned ceilidhs. There's an old Gaelic proverb that says, "A sharing of gold is but brief, but a sharing of song lasts long." And with that, I'd like to officially declare the 2018 CADTH Symposium open. Thank you. Now I'd like to invite our moderator and panelists for our opening plenary to come up and take their places and help us get started with a discussion about health priorities in a changing healthcare landscape. And while they're coming up, I'll introduce the moderator for our opening plenary. It's Pauline Dakin. Pauline is the best-selling author of Run, Hide, Repeat, a memoir of a fugitive childhood. For many years, she was a trusted voice on health issues as the national health reporter for CBC News, and she currently teaches journalism at the University of King's College in Halifax. So Pauline, over to you.
Thank you very much, Brian. And I would say welcome. I think everybody here probably has a pretty good sense of the role of CADTH and what it contributes to the work and the conversation around safe and effective healthcare in this country. But I still remember, as a relatively new health reporter for CBC National News, when I became aware of the reviews from CADTH, or the Canadian Coordinating Office for Health Technology Assessment, as it was known then, and the rich repository of information that it gathered and shared. So just a couple of quick examples that immediately came to mind when I was thinking about the usefulness of that information. 14 years ago, there was a report on Adderall XL, and CADTH recommended that it not be listed. There was no head-to-head data with the non-XR version of the drug to show improved efficacy or compliance, and it was quite a bit more expensive. That was an example of a very relevant story that a lot of journalists were covering and looking for solid information on. So that is an example to me of beyond the expertise in the room, the broader value to the public. And then in 2005, there was a report on the then new metal-on-metal hip replacement technology. CADTH warned there were really no trials or data on which to assess the greater effectiveness or safety. And it was some years later, and I'm sure that you heard about it, that regulators around the world became aware of the problems, a 20% failure rate, and people developing serious tissue issues from metal debris. So again, an early warning from CADTH about some of the concerns around that. So just, again, a couple of examples of stories that I worked on that involved CADTH reviews. And those are the ways in which CADTH has been an important source for evidence-based information on health technology, and not just for the experts, but also for the public. And now, as Brian referred to, CADTH is shifting its focus from health technology assessment at the point of adoption to health technology management. And that means evaluation across the entire life cycle of a drug or technology, and an increased emphasis on supporting decision-making from both an evidence and an economic point of view. So you'll be hearing more about that throughout the conference as leaders here release that new strategic plan. But for this morning, we're talking about health priorities in a changing healthcare landscape. And you will have the opportunity now to hear from senior policy makers from across the country about priorities for improving healthcare and how health technology management can perhaps help with those goals. So let me introduce this panel to you. On my immediate left is Keith Conn. He's the Acting Assistant Deputy Minister of Regional Operations with the First Nations and Inuit Health Branch for Indigenous Services Canada. And then going down the line, Denise Perret is Deputy Minister of the Department of Health and Wellness for the province of Nova Scotia. John Abbott is Deputy Minister of the Department of Health and Community Services for the Government of Newfoundland and Labrador. And at the very far end, Milton Sussman is Deputy Minister of Alberta Health. Welcome to you all, and thank you for being part of this.
Pleasure.
So let me start, Keith, with you. Oh, I just wanted to mention as well, the full bios for these panelists is available to you in the program and also on the mobile app if you're looking for more. But let me start, Keith. Your work is with the new Department of Indigenous Services Canada, and that was established just 7 months ago. Can you give us a sense of what's underway there in terms of Indigenous health?
Okay. Thank you, Pauline. By way of background a bit, I'm Cree from the community of Moose Factory or Moose Cree Nation on the southern shores of James Bay, where I was born and raised. And it's not part of my mugshot bio, so I just thought I'd reference that. So I've been in and out of the health business, I guess, for the last 20 years or so. So it's it's an honor and a privilege to be part of a new organization called Indigenous Services Canada, which is being led by Minister Jane Philpott. So essentially, this is a new department bringing the health determinants, social determinants of health together. So social programs, education, health, infrastructure, housing. So it's a significant opportunity for this government and our ministry. It's really to renew the relationship with Indigenous partners and across the country, to address the socioeconomic health gaps and advance self-determination and more control of programs and services. That's part of our fundamental mandate that pre-existed and will continue. In 2017, as Pauline mentioned, that the Prime Minister announced the plan for a dissolution of the old Indigenous and Northern Affairs Canada department, creating 2 new departments, one being the Indigenous Services Canada, and then the other, the Crown Indigenous Relations and Northern Affairs Canada, CIRNA as it's called. And so our fundamental role is to work in a collaborative spirit of partnership and engagement to ensure that we're promoting and advancing access to high quality services in First Nations and Inuit Métis communities. And CADTH obviously plays a role in that in terms of informing and shaping some of our policy discussions with respect to technologies, pharmaceuticals, which is it's a high volume aspect of our business line. And our vision, part of our support is to empower Indigenous peoples to independently deliver services. Right now we play a strong role in terms of primary health care, nursing services, environmental health services, but we see an incremental movement happening with Indigenous communities across the country to assert their rightful role in managing and delivering services. We have clearly some evidence that shows when these situations occur, we see improved health outcomes, where people own the system as opposed to relying on another government or an agency. That's not to say Indigenous communities need the services of other professionals, perhaps, like the allied health services or pharmacists, the pharmacist community, doctors, of course, realizing that the health system is really run and managed by the provinces and territories, but there's an interplay with the Indigenous communities. Our department, ISC, as it's called, or CSI, I like to refer to it, but no, it's ISC. At least we removed the DIS. There was a Department of Indigenous Services Canada, so we dropped the D, thank God. I advocated for that. I don't want to be dissed, you know, so. So we had our partners, our First Nations partners, making fun of that acronym to begin with, so we had to drop the D. So our key priority areas for the remainder of this government's mandate will be infrastructure, education, child and family services, Jordan's Principle, some of you may have heard of, health services, and the new fiscal relationship. So that guides a lot of our work from a policy lens. So as I mentioned, my branch part of the new Indigenous Services Canada is responsible for the programs and services that contribute to the reduction of gaps in health status between First Nations and Inuit communities and other Canadians. Concrete steps have been taken to develop a new fiscal relationship. We have high-capacity, sophisticated organizations, First Nations, Indigenous organizations, who are running and managing services. So we're looking at a new fiscal relationship where it will be a grant-like structure provided to those organizations and communities to look at some longer-term investments in management of programs and services. We have a lot, excuse me. I have notes here to keep me honest because I have staff here. Oh, by the way, I didn't approve your travel here, Susan. I ran into Susan, one of our staff, just teasing. I did. She said, you did sign it, Keith. So internally to the department continues to work with First Nation Inuit partners to develop this very interesting area, which some of you may have heard of, is culturally competent tools for training employees as a foundation to advancing reconciliation with Indigenous peoples. The department continues to engage and collaborate with Indigenous peoples at a national and regional level towards health transformation, which is a big deal, if I can say that, in terms of large organizations. As some of you may have heard, we had the BC model, or the First Nations Health Authority was created in BC, where we transferred the entire infrastructure of Health Canada at the time to a First Nations-led and controlled health authority. Complete transformation, whereby they are leading the policy and the program implementation, the redesign, or the decolonization of programs and services, if I may. So now we have a larger national frame of health transformation led by Indigenous peoples, and we're a partner in that process. And so we have a lot of northern development, northern initiatives like the Anishinaabe Nation in Northern Ontario that are looking at a vision for the future for their people in terms of a complete restructuring or alignment of programs and services where they will be exercising their rightful role in terms of a health authority of sorts yet to be determined. And that will be through engagement with the communities themselves.
Can I pick up on that point
Yeah.
of health transformation? Because as Brian mentioned last month, the external review of the Pan-Canadian Health Organizations reported back to the Minister of Health. And its first recommendation was about how better to serve the health priorities of Indigenous communities. I'm wondering if you could give an example or what advice you would have in an example of each for CADTH and other organizations on what they should do and what they shouldn't do. So maybe an example of each in the efforts to transform and improve healthcare.
Well, one of our foundational pillars obviously is to improve health outcomes and improve access to quality care. So we do this by working with the Indigenous peoples in partnership. By that I mean we actively engage, we consult, if you want to use that word, but actively engage partners in terms of the dialogue to pinpoint the policy issues or program gaps or deficiencies in the health system locally and regionally and nationally. So we formulate partnership tables with leaders, with Indigenous policy folks or technicians, as some of them call themselves, in terms of the dialogue, creating a dialogue for looking at the exact issues that are facing communities. So it's important to have that open and transparent discussion in terms of policy formulation. Even at the national level, we have our Senior Management Committee, which is the ADMs and regional director generals across the country that have a seat at the table for the Assembly of First Nations and the Inuit, Teputut, Kanatami, and then they have their regional infrastructure where they can engage their own technicians and leaders in terms of bringing policy ideas forward for discussion to populate the policy development process.
So collaborative work.
Very collaborative work. We find that fundamental. That's the relationship's very important. It's key. We need to get the relationship right if we were to actually inform change. It's with us, not about us kind of theme around that's been promoted by Indigenous leaders and community folks. So that's a fundamental principle we operate by.
And would there be a don't do that you would like to tell people about?
Don't do is, one thing we don't do is go out and create a partnership with external bodies or business interests or organizations without having some indication that there's some broad-based support by the Indigenous community or Indigenous communities in a locale or regional or nationally before moving forward. So that's never assume that we'll engage CADTH, for example,
Yep.
directly. We need to have a sense that there's a broad-based support and dialogue with the Indigenous communities themselves, organizationally, regionally, nationally.
We'll come back to some of that, I think. Denise, I guess people here may be aware there has been a fairly intense media attention on health issues in this province so far this year, ranging from doctor shortages to mental health resources and the new single health authority. I'm wondering, what are the key health priorities for Nova Scotia right now, and how are you addressing them?
Thanks, Pauline. It's a bit of an understatement to say it's intense, and it's been going on for a good year, which probably explains the short shelf life, I think, of deputy ministers and ministers in Nova Scotia. But also, there's some concern across the country that the public has been a bit complacent about healthcare, and so we can report that that's not the case in Nova Scotia. A lot of the issues have, not exclusively, but have focused on access to healthcare services. And so the mandate that the government has given the Department of Health and Wellness in Nova Scotia that addresses that part of the equation really focuses on 4 main initiatives. The first is the goal to connect the people of Nova Scotia with the primary healthcare services that they need in a manner that's appropriate. And there's 2 initiatives that flow from that. A really concerted effort on the recruitment front. You mentioned doctor shortage. The recruitment of physicians across the board, but primarily for family physicians, is underway and has really shown some good progress. And as well, a concerted effort to invest and facilitate the development of collaborative health teams so that we're bringing together all healthcare practitioners, which increases access points to provide services in the most appropriate way, to really provide them in a way that's comprehensive and cohesive, focused on what individuals, families, and communities need. So that's a primary thrust of what's going on. In the mental health space, also a need to address wait lists that are far too large. And that's a good thing that we're building capacity in government. So there's an investment in building clinician capacity because we finally come to a point where mental health is valued and has the same priority as physical health. But there still is a way to go to build up the base of that service. So again, a number of initiatives there that are important, building up the capacity in the public sector, which has lagged behind other specialties, but also to recognize that mental health and addictions care has often been outside the main public system. So we have some very excellent resources in the community, but it's a fragmented landscape. And so there's an initiative to look at how we integrate and coordinate those services. I think the government has done a really good thing in focusing on what we call Schools Plus. So creating mental health hubs that service, by the time it rolls out, every school in the province to provide services in that context. And an area that should speak to this audience where I think there's been tremendous progress and that we need to understand and sort through is the virtual care options that are available and how we integrate and coordinate those within the system. Thirdly, a focus on continuing care, keeping people at home with a high quality of life as long as possible, and also an area that really benefits from the development in the health technology front. But we're focused here not just on what the patient needs to stay at home, how we support self-care, but a real effort to focus on caregivers and what they need to ensure that they can provide care in a safe manner, and also that their needs are supported. So again, we look at what sort of virtual care resources we might have for psychosocial supports that help that community. And as we go into the long-term care side of the equation, Nova Scotia has a poor, I will say, record on some of the workplace safety initiatives. And so we need to look, and again, technology has a big role to play, on how we provide care in that forum in a safe manner, in a manner that maintains the dignity and care of residents in a comprehensive fashion. And then the fourth major initiative on the access front is and if Kai-Hi's here, your report last week was a reminder we have a long way to go, is that we want to reduce wait times for orthopedic surgeries, for hip and knee surgeries. And the Kai-Hi report, which I reviewed quickly, indicates across the country generally that wait times are actually going up and down. And that's because, in part, technology has come in and allowed those types of services to be provided effectively to a broader range of people. So demand goes up. But we are committed. We're running uphill on that one, I guess, but committed to addressing that issue. So just in closing those comments, I think the common theme there, with the exception of orthopedic surgery, is that the focus of this government and providing effective services, appropriate services to people of Nova Scotia is really focused on how you build capacity in the community and starting to move that transition and really facilitate it away from those two pillars of acute care and physician care to a much broader base.
Can I also ask you to briefly talk a little bit about what the transition to the single health authority, what impact is that having as you sort of focus on these goals?
So also the subject of much of the public discourse in the province. From my perspective, and I come from a province that had that initiative a number of years ago, it's a positive move, especially when you look at the size of Nova Scotia and how it's laid out, to create a provincial platform for the provision of healthcare services that can be provided in a very efficient and effective way is a good thing. And I think there's been good progress on that front. But I have to say two other things, is that, and I think it gets forgotten in these types of transitions, is that there's layers to it. They're corporate mergers. And in the first layer, which in some respects it's massive, but it's almost the easy part, you bring the organizations together administratively, and you bring payroll systems and IT systems, and you create one. But the trick of it is in the next two layers. The work that needs to be done to re-engineer all of those healthcare services and processes within, in this case, 9 organizations that come together. Because on orthopedic surgery, how we're going to move forward is actually being able to bring 9 systems together and find efficiencies and effectiveness and areas of expertise. So it's less fragmented and much more cohesive. But the real super sauce in it is the third layer of has to happen. And that's a hard thing in these mergers, is that you need to centralize to bring the systems together. But the secret sauce is learning how to devolve some of that decision-making and maintain a connection with local communities. Because re-engineering is about removing, inappropriate variation in the systems and standardizing and deciding where you're most effective. But you can't lose the connection with local communities. You can't lose sight of some variations required, because the population varies across the province and there's different needs. And so it has to respond on that local level as well. So I think there's good work being done. I think it is definitely on the right track. But I don't think the transition is over yet. We're still watching it in play.
Thank you. John Abbott, I understand that you're just back from a meeting of the Conference of Deputy Ministers of Health. What are the common priorities that governments across the country are dealing with?
Well, now, I will have to say I did not make the meeting due to a common cold. So,
is it a question you can still address?
I think so. I'll give it a good try anyway. And actually, we've come, I think, we're at a good place, I think, in Canada right now with federal leadership around developing common priorities. So the governments in the past year signed off on a set of common priorities when it comes to mental health and addictions and home and community care. And that process, at least from a Newfoundland Labrador perspective, I thought went quite well. The federal government was open to our ideas. We were open to theirs, and over a relatively short period of time, we're able to develop these priorities, develop action plans, and it's certainly in our case put dollars into the programs that met the priorities of our jurisdiction, and I think really that was true right across the country. That's in that particular area. Now, we talked about the opioid crisis across the country. Again, good evidence where jurisdictions have come together, again, with the federal government to look at what's starting in BC and how it's working from west to east. And it gives us sometimes a day, a week, a month advance notice of what's coming our way. But there's a lot of coordination, a lot of conversations, and we are making inroads, albeit, it's still in that crisis mode. But at the political and bureaucratic and policy level, I think we've come together quite well. So when you look across the spectrum, there are a lot of other areas that we need to focus on. Primary health care is certainly a case in point in our jurisdiction, and we are working with and learning from other jurisdictions as we move forward. But the thing that helps our jurisdiction is that we can call on the national health agencies, including Health Canada, to where's the evidence, where's the information, where's the analysis, and how then can we apply it. So if you look at it from again in Newfoundland, Labrador, we have some of the highest spending per capita on health. We have some of the poorest outcomes, and we are challenged to fix both sides of that equation, as it were. So we've in our work have tried to bring all these pieces together. We use the Triple Aim framework as the basis to help us pull these pieces together. How can we improve patient care? That's obviously priority one. How do we improve the population overall? And then how can we do that on a cost-effective basis? And for us to be successful, we have to use the best evidence, the best practices across the country or across the world, wherever we can find it, and be prepared to apply it. And that's sort of our immediate challenge. That means people, systems, clinicians, patients all need to change to drive towards that ultimate goal, which is that we will have and should have some of the best healthcare and healthcare outcomes. We're on that journey. We are seeing the opportunities. We're seizing on those. We work with CADTH as a case in point to help inform our work. And I'm optimistic that give us another 3 to 5 years, we will start to see some significant improvements. Our minister is very focused on engaging both the communities and the clinicians in change, and that's really been well received, I think, in our world. And I'm again optimistic that we will see through this over the next couple of years.
There's been an increased focus on collaboration between health departments in the Atlantic region specifically. What's the impact of that? What impact is it having?
Well, Denise is here. I think Tom Maston from New Brunswick and Kim Fishley from PI are here today, and we meet and talk regularly, as late as last night, though Denise had other plans. But it was, again, a good conversation. But what we have the same challenges. We all could do with more resources, but we know that there's a limited amount. And we have identified particular areas that we can focus on. Home dialysis as a case in point, blood product utilization, so very specific areas that we honed in on to say, how can we, with the best evidence and the data that's available, to make change, engage the clinicians, engage the patients, and then, but be resolved in that we do need to move forward. Again, mental health and addictions is an area that we are having a lot of conversations on what each jurisdiction is doing and how we can do it better. We're working with Canada Health Infoway on some technology and information management solutions there. So it's a new area for us, but our premiers meet on a regular basis, and their expectation, of course, is that we show results, and so that's what we're about there.
Thank you. Milton Sussman, you're a recent appointment to Alberta Health, but you spent many years in senior health roles in Manitoba. What are you finding are the similarities and then also the differences between Manitoba and Alberta in terms of priorities and challenges and strategies?
Well, it's interesting to me, since I've just finished 6 months in Alberta, so quite new. But what struck me is just how similar the issues both provinces are dealing with. And actually, from what Denise and John said, the issues in healthcare are across the country. We all face many of the challenges. Both Manitoba and Alberta, the rate of growth of healthcare spending has traditionally been significantly higher than the rate of growth in the province. And now both provinces are trying to make their health systems much more sustainable. So there is a significant focus on sustainability in both provinces. Both provinces certainly have a larger focus on acute care, but have come to recognize that really we have to shift care out of acute care so that it's providing the appropriate services, but much more of a shift to a community-based provision of health care. I think that's going on across the country. So there are significant initiatives in Alberta to enhance its primary health care system, to advance its community-based care system. John talked about the recent initiatives with the federal government on home and community care and mental health services. Those continue to be issues in both provinces. I think one of the big differences is the extent of the opioid crisis in Alberta is significantly higher than it was in Manitoba, and is having a much more profound effect, I think, to date. But certainly the issues of wait times. Alberta doesn't have the challenge of recruiting doctors, but it does have the challenge of a maldistribution of doctors. Both provinces are large geographic areas, but with large urban centers that dominate where most of the clinical resources are and where the well-trained specialists are. And it's often very difficult to get appropriate healthcare professionals into more northern and rural locations, and those remain a challenge in both provinces. And the whole issue of the outcomes for Indigenous people in both provinces, they're significantly below what the rest of Albertans or the rest of Manitobans were. Both provinces are very focused on reconciliation with Indigenous people and trying to work with Indigenous people to improve the healthcare delivery system. So there's significant efforts in Alberta now towards recognition and towards creation of tables that would work towar's that.
How are you finding working with the new framework of Indigenous Health Canada?
Well, we've had our first, I went to Ottawa and met with the Deputy of Indigenous Services Canada, and I was quite encouraged by the approach that they were taking and the willingness of certainly the Deputy to engage with provinces and to look at ways that we could partner to move the work forward. I do look forward to Indigenous Services Canada interacting more with the Conference of Deputies. To date, we haven't had much contact. I think that is an area that I think they've started to recognize that they need to engage with jurisdictions. I think it is something that we need to actively engage as a collective with Indigenous Services Canada, but also on a province-to-province basis or province to federal government basis.
Thank you very much. We're going to drill down a bit on some of the things that the panelists have mentioned, but just a couple of housekeeping things before we do that. One is that there will be an opportunity for your questions, and I want to tell you a bit about how you get those questions into the queue. So you'll find question sheets on your table. You write your question and then just hold it up, and there will be folks on the team who will come by and pick it up, and they'll bring them to me. And you can submit questions at any point now. So if I see one coming up right there. So if if questions are arising while we're speaking, feel free to put that question in play right now. The other thing is just a question for Peter, because I thought there was going to be a clock on the screen. So would you give me the 15-minute mark? That would be great. Okay, so let's move on to a little bit more focus on technologies. I want to start with John Abbott. You're a member of the CADTH Board of Directors. How do you see the organization's shift to health technology management helping you in Newfoundland and Labrador?
A great question because it's an easy one to ask and one that I know CADTH is trying to answer for us and for the country as a whole. One, making the shift from, I'll call it the health technology assessment and largely focused on drug technologies up till the recent time, moving into medical devices and other technologies and looking at literally the life cycle is going to is something we need as a jurisdiction. I mean, we are inundated with requests from whether it's patients or advocacy groups, from clinicians, and from the industry itself to put all of these technologies in play and fund those and see what happens. And we're saying, well, there's a limited budget, but that issue aside is really what is appropriate, what is effective, what is cost effective. I had a call just this past week from a colleague of mine who's now retired, who's looking for a particular drug for his particular disease, but it hasn't passed the test. And those issues are brought forward to my office, our CEO's offices, and certainly our minister's office and the Premier's office on a daily basis. And what helps us as a department is that we can call on CADTH to say, what have you in your inventory of analysis and recommendations to deal with these arrays of whether drugs or devices? What is your best advice? What can we realistically address in this time frame? And I can only see their work improving and expanding and improving as time moves on. We have catch up to do here in Canada. Other jurisdictions, other countries have dealt with this a little bit earlier, probably a little bit more effectively. And so I'm bullish on the need for CADTH to really step up. And as a board member, that's certainly one of the things that I'm wanting to bring to that table is how can we accelerate, improve, and really add value to the system, both at a national level, at the provincial level, and at the local level, and almost at the bedside, that clinicians in the conversations that they're having with their patients to say, look, here's, quote unquote, here's what the evidence is, here is what we think is reasonable, and that there will be acceptance of that. You're not going to be able to solve, obviously, all issues, but we need to have some backstop, and that's really how I look at CADTH and some of our other national agencies as a backstop to decision making in our province and across the country. So I'm optimistic that that will only improve with time.
Thank you very much. Good news, questions are starting to come in. Kevin Conn, what are the specific issues facing Indigenous peoples when it comes to drugs and medical devices?
Good question. It's an ongoing challenge for sure. When you think about the 633 communities across the country, a number of them are remote, rural, or fly-in, if you will, when we use the term remote. So it's in terms of accessing pharmaceutical care and hospital services. For example, we have clients that are living in communities, in remote communities, that have their non-urgent medications flown in when required and then stockpiled in a nursing station. However, medications are dispensed in the nursing station for those who require quicker access to medication for acute conditions. Instead, this function is performed by nurses using a mostly manual processes such as hand labeling medications and charting. So a similar challenge exists for access to medical devices. Currently, when a client requires specialized medical services, they'll often have to leave their community and their families and their support network. So this could also have a determining factor in terms of people accessing needed services. So our branch is working currently to address the challenges related to access through new investments announced in 2017 in terms of e-pharmacy. We're looking at a number of pilot projects to implement in create a remote presence technologies to provide access to specialized services within communities. With regard to what health technology assessment organizations can do to improve health outcomes, I think I'd like to re-emphasize again is the working in partnership with the First Nations communities and governments when it comes to improving health outcomes for Indigenous peoples. So there's a lot of unique challenges for sure, but I think the aspect of having a transparent discussion and engagement is key. We've experienced benefits as well, and a clear-cut example is we have a national joint review with the Assembly First Nations and its membership in terms of examining some of our irritants, if you will, we call them, in terms of the administration of our non-insured health benefits programs, which is transportation, dental, pharmacy care, medical supplies and equipment. Through our partnership table, we were able to drill down on some of these irritants and policy gaps or program gaps to create change, which includes looking at prescription drugs, medical devices for clients, and so we're looking at policy improvements. So that's a recent example. That's an ongoing process. We've dealt with mental health, the mental health directive that exists under the program. We've completed dental, and so we'll be looking at we completed vision, excuse me. We'll be looking at medical transportation and pharmaceuticals. So it's a good process. It's an open process, and I think that's leading to a fundamental change around the administration of the program.
Okay, thank you. Denise, when you're looking at new technology, what are the things you need to think about before you adopt it? And what's helpful to you then in terms of technology management?
So that's a big question.
Yes, I know.
So here's how I break it down, and I'm guilty of being overly simplistic. But I think there's three categories of questions and analysis that have to come to bear. And it's the does it, will it, and is it. The does it part of the equation is whether the technology does do what it claims to do. Is it going to be appropriate care for your health system? Is it safe, and has it passed all the quality factors? And as I say, does it do what it says it's going to do? And I think too often we've regarded passing sort of that test as that's good enough. But that's just one part of the equation, because then you have to go to the will it. And the will it part is, will it actually fit into your healthcare system? Do you have providers that are going to be comfortable with this technology? Do they feel supported in adopting it? Is there enough information? Is there training? Are there guidelines in place? Do we have the regulatory structure in place? Do we have security if it involves, and protection of patient information if that's engaged? And so that whole implementation phase, but pre-implementation assessing about will it work in the environment that it's being introduced to is critically important. And then if it gets past that that stage and it's in play, you got to ask the question about, is it? And once it's engaged, and this is kind of the, do you continue to invest or disinvest, or how do you pivot when things change, is it doing what it said it would do? Does it in fact work? Are we getting better patient outcomes? Is there a return on the investment? And is there an eye on that play, so that if the answer is no, that you're looking at disinvesting, that you're very conscious of what gains you're making and you know how to course correct? Or in some cases, and this is highly disruptive in the system, the technology actually fails in the sense that the company may be sold and the product or the technology phased out or discontinued. And that type of disruption takes the system off its main game. And then you have to focus, and a lot of time and financial investment and a lost opportunity cost is involved in pivoting on that. So, you know, it's a very complex landscape, and decision-making has to be well thought through. And that's where I'll put in the plug for CADTH's strategic plan, because I think the plan, which I just read on the weekend, is extremely good and brings clarity to the number of dimensions that have to be considered. And obviously in that process, you're looking for, it's a bit like having a financial advisor on the stock market. You need to have your health technology advisors that are guiding you through the system and looking down the road to tell you what you need to have your head up and be prepared for.
Thank you. And Milton, Sussman, what do you see as the role of governments, and I'm thinking specifically health ministries, in terms of supporting innovation?
I think governments actually have a tremendous role in supporting innovation. I think they've got to create environments where they actually talk about supporting innovation and put some resources into that. I know in Alberta there's a strong focus on driving innovation, both within its main service delivery arm, Alberta Health Services, and they've put a tremendous focus on strategic clinical networks and helping to drive innovation based on best practice and looking at what the evidence is, and trying to really create opportunities to drive innovation across a number of priority areas. Alberta's also put a large focus on research and linking the research to what the priorities of the health system are, and have created a whole research framework and engaged with both of the major universities in Alberta to help drive that innovation. I think one of the challenges that I think health systems and ministries have always had is trying to actually to differentiate the procurement processes from allowing innovation into its system. So I'll give you an example. In Manitoba, we were so focused on how we would do procurement and how we would avoid a bias against linking with one particular company, that we actually made it difficult for innovative kinds of technologies or innovative kinds of solutions that were designed in Manitoba from actually being tested in Manitoba. And I think there has to be a way that we look to bridge those kinds of gaps. And in this year, actually, we are looking to put forward a small fund that will actually support driving innovation, not so much creating that innovation, but actually spreading the innovation and actually getting spread across the system. So we've put $5 million into a fund that we're looking to leverage with other kinds of funds to help that spread of innovation, because that's been one of the challenges, is there will be an innovation, but then it's not well adopted throughout the system. So I think government can play a critical role in trying to move this forward.
Thank you. And now we're at the point where we can turn to some of the questions and there are lots of them, I'm happy to say, from the audience. And I want to start with one that has, political overtones for sure. The question is, in your view, what are the advantages and disadvantages of a national pharmacare program? Is there anybody who'd like to jump in on that? It's a question for all, but we'll see who wants to jump on that.
Well, I'll start. There's no downside. I'll start there. There's been a lot of work, a lot of conversations in this country around, a pharmacare program or strategy or policy for the country. What it looks like, how it's designed, will vary, I think, by where you sit. But there is no doubt in my mind that that's something we have to move forward to achieve. Access shouldn't depend on where you live, what income you have. So if once the principles are agreed on, I think then we can move forward. And in many respects, we're probably not that far off. If you look at each jurisdiction and how they and we have approached that. I know in Newfoundland and Labrador, we have designed a program that tries to reach, quite a large part of our population. And so we have in a provincial program, 30 to 40% of our population that would be covered in one form or another. And then there's private providers and what have you. So the gap isn't that far off. But again, to the way Denise talked about, is then, but what drugs do we need? What drugs should we have? And then obviously their efficacy and their cost effectiveness needs to be uppermost. We have, with the Pan-Canadian Alliance now, at least now have a tool in place to allow us to negotiate prices with the manufacturers, and that's paying big dividends. So again, if you can bring all those pieces together, I think with the political leadership, certainly from Ottawa, but also from the provincial capital and territorial capitals, we should have something in place, hopefully sooner than later.
Okay, thank you. For Denise, could you speak to the progress around electronic health records? Is there a national conversation or other information sharing that will inform how personal health information is gathered, protected, and used? Relevant within the last week, for sure.
The development of in Nova Scotia, what we call one patient, one record, and having a coordinated place for patient information is critically important. It is a topic across the country. Provinces are at various states of where that's being advanced, and we do have a rallying point around Canada Infoway to provide advice and assistance on some of that front. We have a lot of other partners in that space. Certainly in Nova Scotia, we're making good progress. It's quite exciting to see how this initiative is moving forward. It is a complex and important initiative to get right. You're alluding to a breach of health not personal information, not necessarily health information that occurred in the province. So obviously it has to be done carefully. It needs the right kind of security and checks and balances in the system. But the opportunities that are presented is a foundational piece. The opportunities that are presented both for the healthcare system and improving value in healthcare, but also for business development and the types of technologies that we can bring forward is exciting and absolutely has to happen.
Question for you, Keith. How do you balance the funding and use of Indigenous medicines or interventions with Western medicine?
That's a great question. That was actually, I think it was call to action number 22, I believe, called for the valuing and respecting traditional healing practices, including medicines. So that's something that needs to be fully explored. The balance, I think that's really an autonomous question to be posed to the Indigenous populations wholeheartedly. We do have some interesting pockets of heaven where traditional healing and medicines are actually blended in with Western approaches in some hospital settings. In Conn, I believe, the Whitehorse General Hospital has an adaptation of traditional healing and practices and medicines and foods, and the physicians and nurses fully embrace that approach. So we actually have a budget 2017 commitment for traditional healing and practices to support that. So we're early days in terms of engaging First Nations partners in terms of how to define that, how would they manage and govern that to have a blended approach. Certainly, a lot of our healing practices, which partially includes medicines, is land-based activities. There's a regeneration, a resurgence of that effort as part of the holistic approach to healing.
Okay. There's a bit of a theme happening in some of these questions. A number of people asking about the opioid problem. So let's do a little 1-2 punch here. Milton, Sussman, maybe I can start with you. The first part being, are the provinces and territories able to end the opioid crisis, or do we need a more firm response from the federal government? And an addendum to that question being, is it a criminal investigation of opioid marketing needed?
At this point, I think it's too early to say if we can end the crisis. Certainly, the deaths are still increasing in both Alberta and British Columbia. We haven't seen that abate yet. There have been a number of initiatives done within the province of Alberta, and I know within the province of British Columbia to try and address that. Now, it's probably too early to tell what the efficacy of the initiatives in Alberta have been. We've rolled out a significant number in the last year, but the deaths continue to increase. I think there is good cooperation on this from the federal government. They've done some things to help quicken how we could do safe consumption sites and other measures. And I know in the recent budget they've announced a large initiative to try and address the opioid crisis. It's not clear to me yet that we know how to connect with all of the people who are using opioids. Particularly, I think many of our interventions have focused on the traditional at-risk populations. They haven't really been as effective in looking at ways to address the number of people that are non-sort of traditional at-risk, the people who live in more of the suburbs who are dying from the opioid crisis. I think, is there, on the second part of the question, certainly I think there needs to be a look at how opioids are marketed, but I think we're still not fully understanding the complexity of the problem, and I think that's going to still take some time.
Okay. And for a follow-up opioid question, John Abbott, I'll ask you, do you think now that I don't know if I'm going to get this right, is it the eDocs and SNL program? Has been launched and all pharmacies have been connected through the pharmacy network. Do you think that can help in overcoming the opioid crisis across Newfoundland?
I guess in itself, I would probably have to say no, but it's one of the tools we have of linking the prescriber with the prescription and obviously the user. We've just put in legislation with prescription monitoring program. Focused certainly in the first instance on opioid use. But what still is there and confronts all of us is we still have, with the physician community still prescribing at a rate that is, in my view, questionable. And so I think if there's one sector that really needs to focus and look at itself, is certainly the medical community to challenge themselves and how they can change, and in changing, obviously supporting their patients. So that needs to happen. And then of course you got the illegal market, and that's obviously a role for the federal government and the criminal justice system and others to address that. But if you get behind the reporting, and certainly the work that Alberta is doing, I find their reports very, very informative, because they're getting behind the big numbers and getting it down to who's prescribing, who's using, what communities. So we're getting much more better intelligence, and certainly we need more of that, and to really inform both, certainly public policy direction going forward. There is a high degree of cooperation. There's a lot of information sharing between governments, including the federal government. I think everybody's focused on the same issue, wanting to solve it, but there's a lot more needs to happen. And then you get obviously behind the social determinants and all of those factors as well. When you get down to who's actually in crisis, then we got to focus on that part of the system as well.
I see other heads nodding. Yeah. Thank you. Denise, a question for you. In terms of the is it working aspect of medical devices, how do we ensure we have the evidence from the real world to make this decision?
So I think actually Milton referred to it. We need to be connected into those areas that have the expertise to advise us. We need to have close connections and collaborations with our universities, with health technology assessment organizations, with the information that vendors and other stakeholders are putting forward. And it's a considerable effort. I think I would agree with Milton. Alberta has put in place some very good coordinating mechanisms on that front. I got to be part of that environment for a while, and I think it has a lot of potential. So the trick of it is to be paying attention to it, to recognize that it's a key part of moving our health systems forward. And as I say, there's a number of layers of decision making that have to be gone through. So you do have to, if you don't have it in-house and if you don't have those connections already wired, there has to be a concerted effort to be working with the research community to establish that.
Okay. We have a question from a patient member today, and this is for Keith. Keith, could you provide an example of how Indigenous health services build and foster collaborative practices that other health services might learn from?
Great question. We do have promising practices, obviously, in terms of, think of the Sioux Lookout First Nations Health Authority, which is looking at practices, broadly speaking, for Northwestern Ontario and their member communities in terms of primary care, preventative public health programming, redefined as a community wellness initiative, something more familiar with the health determinants approach from an Indigenous perspective. So there are practices out there that are emerging and growing and evolving. We also have the I mentioned earlier, the First Nations Health Authority in British Columbia, which is unpacking, if you will, some colonial processes to look at sort of Indigenous perspectives from a community point of view in terms of practices and in terms of care. We also have, in the world of mental health, we have what is called trauma-informed care, because we're looking at individuals and patients who have, generally speaking, have suffered either some debilitating issues resulting from intergenerational trauma, residential schools, violence. So, and a trauma-informed approach and care practice is something that's has taken shape, has taken form. So we're looking at various, the Native Thunderbird Foundation has been well informed about those practices and gathering resources to share out to communities and providers. So those are a couple of examples.
Interesting example, yeah. Yeah. We also have a question from one of the students attending the conference. This is for Milton Sussman. As elected, actually it is meant to be for the full panel. Milton, maybe you can weigh in, and if anybody else wants to add, that would be fine. As elected political officials, how would you reconcile situations where the public is demanding a drug or technology, but CADTH has determined that it is not cost effective?
It's always challenging to speak for an elected official as a non-elected official.
True, yeah.
Go for it.
I think it's very difficult. My experience in working with a number of ministers is it's a very difficult thing. Certainly, when I was first a deputy, drug companies made a point of trying to leverage patients to influence decisions of governments to fund new drugs. I think some of the work that has happened since then across the country, some of the pan-Canadian work has helped to stop some of that. But I think what most ministers who are confronted with this go through in their head is, I think, particularly if they've been briefed by their departments, they will try and look at what the efficacy of the drug is. Is it cost effective? Will it actually get the results? Very similar to what Denise talked about, the health assessment. And I think more commonly now, most of the time, I think ministers rely on the pan-Canadian approach to addressing new drugs and leave it to that. And that has become their way of answering because it is, I think, a nonpartisan kind of look at whether drug plans should fund those drugs.
Anybody else want to jump in on that?
Sure. I wouldn't mind. Well, certainly we at Indigenous Services Canada, in terms of the administration of our pharmaceutical formulary and medical supplies and equipment, generally follow the lead of CADTH and its good advice. And then there are at times some exceptional situations that we have to consider internally and not just look at cost, but its accessibility and efficacy in terms of a specific case, a specific client, which has a lot of visibility. I could safely say that, there's been some fundamental historical inequalities in terms of health services and access and funding for health programs and services for Indigenous communities. We are attempting to correct that with some substantive investments of the recent 3 budgets. So my point is that we'll follow the lead, but in certain circumstances, we may have to look at some exceptions despite the cost. But we need to look at some of the efficacies of the particular drug in a particular situation. There's unique situations we need to re-examine.
Case by case.
Case by case.
Yeah. Denise?
Thank you. So I agree with the comments that have been made. I would just emphasize, and I've worked for quite a few health ministers, that they are hard decisions that come forward, and what is reassuring is the time and attention that's paid to that decision-making process, and that's really where you actually see some of the family and patient perspective brought into the discussion, which is both helpful and sometimes heart-wrenching. So I don't think those decisions are ever, in my experience, made lightly, and they are generally very thoughtful.
There also is, I think in most jurisdictions, an exceptional drug kind of process where there will be some kind of other review of whether on a one-time basis that there might be some funding for a certain drug.
This question, this person has not identified who they would like to ask it of, but I'm going to ask you, John, because you are on the board of CADTH. Everyone has talked about integrating healthcare for better patient outcomes. How have you engaged patients in your deliberations and implementation?
Again, it's going to, the answer there depends on really which part of the system you're going to address. So in our health authorities, I think that whole area of patient engagement is evolving. Certain jurisdictions are further ahead than others, but it needs to be a fundamental component. In terms of the research we do, whether it's at the local, provincial, national level, patients are and should be fully engaged in the design and of the research and participate in that. And certainly when it comes to drugs, I know in CADTH it's a very active part of our work that patients are immersed in the work. And as a result of that, obviously you get a better result, you get a better product. But what's also interesting, from my experience and the literature I've read, when patients are in the room with clinicians and others, the nature of the conversation changes considerably. So when you just have quote-unquote clinicians or quote-unquote just researchers, it's very technical kind of a discussion, sort of devoid of many times of the human dimension. Bring the patient in with the human dimension, then that conversation and the results can and will vary from if they're not there. And that helps us to have, when we talk about patient-centered care, then that's what we really mean. Many of us give lip service to it, and we really need to, and I know in my own jurisdiction, we need to do a lot more around bringing the patient voice and experience at all levels, and only then will we, get the best result. And sort of in terms of the former question, again, bringing the patient and the researcher and the politician in the room to talk about a drug that may not be being approved through the CADTH and other related processes, again, changes the discussion as well. And what I found surprising results, then the patients and families actually become more informed themselves and are more accepting of the quote-unquote decision if it is not to fund. And that's surprised me on numerous occasions.
Okay, thank you. I wonder if I can get Keith and Denise to weigh in on this one. It says, primary care is the cornerstone of our Canadian healthcare system. Why has Indigenous Services Canada not looked more broadly at employing family physicians on reserves? Keith, do you want to start?
Sure. So we have a challenge for sure in terms of physician days, especially in the remote flying communities. So we have different contractual arrangements with physicians in the various jurisdictions, territories, and provinces alike around arrangements to increase that complement to have them accessing communities. And we've got some ways to go. Certainly there are some unique situations where communities have themselves attracted and have salaried physicians, but that's not universal. It's sort of a challenge, to say the least, around having, it is a different environment for sure, to put it politely. It's intriguing for some, it's interesting, it's challenging, job satisfaction elements enter the equation of, flying into communities, providing services. It's not for everyone, I could say safely. Some people prefer the comfort of their office in downtown Calgary. I mean, I'm not saying that's a wrong thing, I'm just saying, so we've got issues in for Canadians alike in terms of rural and remote situations. So it's even compounded with the northern Indigenous communities' location, geographical challenges. Housing is an issue, accommodations. So I'll stop there before I go into the ditch.
Okay.
But we're working on it with the various physician groups and jurisdictions.
Okay, thanks. I was going to get you to weigh in on that too, Denise, but actually we're running out of time and there is a different question that somebody would like to ask you. So let's jump onto that, which is, what needs to change to be ready for personalized medicine, or are we already there?
Okay, that's a very hard question in many respects, because I think we're still in early days of personalized medicine and understanding the nature and scope of how it's going to be applied. That's an area where we do need to have good connections into the health, with clinicians, with the research community, and to understand, I would go to my questions about, are the therapies, is the approach, is it doing what it says it will do? Will it fit into the healthcare system where you're working? And can you sustain it? Is it going to be appropriate? It just needs the rigor of that kind of review. There's a lot of pressure points there. There's a lot of promise that it would seem, and we really need to see if that plays out, to be quite frank, and whether we can accommodate it in a very appropriate way that, at the end of the day, improves patient outcomes.
Not there yet.
Well, I think it's an evolving area where it puts an emphasis on the need for the system to be connected and integrated as it approaches it. Far too often, we've grown the Canadian healthcare system in an ad hoc, fashion, in an incremental fashion, and it's time where we really focus on things. We need to have a focus and finish attitude to some of these key initiatives. Yeah.
Okay, thank you. We've covered a lot of ground and, tried to address some very large topics. But I think as we wrap up, I would ask if each of you could give a very brief thought as you are moving forward in this conference and dealing with these issues. What key piece of advice would you like to leave this audience with? Just very briefly. I'll start with Milton.
Well, I think that the key advice I would offer is the challenge is significant, but it impacts all Canadians. Healthcare is probably the only thing that impacts every single Canadian, and it is something that we have to continue to improve. We have to get the kind of outcomes that Canadians expect and need. And I think we need to focus on finding different paths to do that. And it's a complex environment. Our job is really to try and find ways to improve patients' experience and to actually make our system sustainable and effective. And so my advice would be to embrace the challenge.
John?
If you just go back to your previous question to Denise, so personalized medicine and then population health. And when you look at, and that's going to be sort of some of the big policy issues we're literally going to face going forward, because what is good for the individual and the sum of the individuals may drive you in one direction, where from a population health perspective, you look at what we're trying to address when it comes to Indigenous health, as a case in point, really needs to look at it in a more global perspective. So that those kinds of issues going forward, and really for me, it's making sure our leaders lead, and that we, as wherever we are in the system, hold our leaders accountable, whether it's the clinician leader, the administrative leader, the political leader, or in my case, I guess, the bureaucratic leadership within the health system, to really focus on change, that the status quo is not is not sustainable, whatever way you cut it. And we all have to be prepared to do our part in that change. And yesterday evening when I went down and walked through to look at all the posters, and I'm saying, what about if we implemented every single one of those great research ideas? Where would we be in a year's time or 3 years' time? And so we need to bring in the talent, bring in the new ideas, not be afraid of embracing those ideas and really foment change right throughout the system. But that leadership has to be there to allow that to happen. And if a leader is blocking change, then he or she is no longer a leader, in my view. It's time for somebody else to step into the breach and to drive it forward.
Okay, thank you. Denise?
So I agree. I mean, the healthcare system in Canada is in transition, and it needs to be in transition. When you look at, I think the July 27 Commonwealth Fund report, I don't know how we can see the results of our system compared to comparable countries and sit back and be complacent, because we don't do well. And we don't do well on things like access, which is both affordability and the ability to secure the services you need. So we need to act. We need to come together and decide, if we're going to row in the same direction with giving effect to this transition. As I said earlier, so much of our healthcare system is characterized by just ad hoc incremental change. We are very still a fragmented system, and we need to quit looking at just inputs and process. And as everyone is saying, we need to have a real eye on outputs and how we're impacting population health. There's a very good article, the Dean's blog from Queen's University Medicine, which is a compilation of, I think, something Queen's did in their School of Public Policy. So that blog came out in January of this year, and I would recommend that everyone read it. It's very short, it's very provocative, but it is a bit of a cry to action that I think we need to pay attention to.
Last word to you, Keith.
Well, we're in a very historical time, is what I can say, in terms of this government's commitment and mandate for Indigenous peoples in all spectrums of socioeconomic health and well-being and so forth. So my mark would be focused on is the real meaningful partnerships that have depth and breadth and outcomes in terms of the goals that we want to achieve together with Indigenous peoples. So we're doing that, and we need to do more. We, being the royal we, federal government, provincial, territorial governments, we're doing very well, and I think, in my humble estimation, in Ontario and Alberta and Nova Scotia, we've got work to do in other areas in looking at tripartite discussions, collaborative efforts, because no one jurisdiction can do it alone. We need to work together in a meaningful way. And CADTH is one of many organizations that could be a part of that partnership journey and pathway forward. I know we're doing some good work right now as we speak with CADTH. Absolutely. We can strengthen that work and energy.
Okay. Thank you to the panel members we've put you through your paces with all our questions today, and thank you for such great questions from the audience. That will wrap up the opening plenary. I wish you a great conference. Thank you.